Okay, good afternoon, guys. Little thin turnout, obviously. GMC is not on Wednesdays. Today we have Alan, one of our good UITs. He's going to be talking about advances in telehealth. So take it away, Alan.
All right. Hi, everyone. So I'm Alan Truong, one of the second-year medical residents here. I want to do this topic that I thought was pretty cool. Advances in telehealth, redefining healthcare delivery. So first off, why telehealth? Like, why do this topic? I did a word cloud because Dr. Fried likes word clouds. It's a rapidly growing field, lots of advancements in technology. The industry is burgeoning. It's starting to be embraced by lots of hospitals, insurers, patients, and physicians. And basically, I think that having a basic understanding of telehealth is going to be essential for practicing modern medicine going forward in the 21st century. Just doing a slight Google trend for telehealth searches in the last 10 years. Certainly you can see in the last 3-4 years, people have started to search for telehealth a lot more. And if you look at the map down there, a lot more in the rural kind of regions, but some metropolitan areas as well. So the objectives for this talk are fivefold. We're going to define telehealth, look at its different categories. We're going to describe a brief history of telehealth, just very brief. Look at the evidence base for the telehealth applications, focusing a little bit on primary care, but some other stuff too. Looking at some hurdles to implementation, this is a big one. And distinguishing it as a stronghold of modern practice, basically to say that it's here to stay. So definitions. So when I first looked into this, it seemed like telemedicine was the more popular term, I thought, at the time. It's Latin for medicus, Greek for tele, healing at a distance, basically remotely diagnosing, monitoring, treating patients. And at first, it seemed like the main difference between these two terms was that telehealth is a little bit more broad. It seems to encompass more health professionals other than just doctors. But really, it goes to show that there's over 100 definitions of telehealth, and a lot of people, like a lot of organizations like World Health Organization and even American Telemedicine Association, will use them interchangeably. So the World Health definition, basically it's like delivering healthcare services where distance is a critical factor with healthcare professionals using a bunch of different technology to communicate, exchanging diagnosis information, treatment, prevention of disease, and then also involving continuing education of healthcare providers and patients, and all in the interest of advancing the health of everyone, basically. So I'm just going to categorize telehealth in two ways. This is the first way. I'll get to the second one later. The first one is real-time, remote patient monitoring, and store and forward. So real-time is pretty self-explanatory. It's like, doing things in real time, video conferencing with patients, calling them on the phone, having the home nurse look at them and you look at them through the video. Remote patient monitoring, it's kind of this cool thing that's basically monitoring a bunch of different parameters at home that could be sent in electronically, remotely from another location to the provider. This can include medical grade devices like glucometers, blood pressure, stuff like that, or even emergence of wearable health tech like Fitbit and stuff. But I'll get to that later. It's not quite there yet. And the last one is store and forward. This one, doesn't seem as novel anymore. It used to be. It's pretty mainstream now. It's when you get a bunch of imaging labs notes, put it into an encrypted file, and send it electronically somewhere. And just going over a few things that are not telehealth. This first one's a little controversial, but remote education. Basically, if we're doing UWorld online or looking at UpToDate, that's not really considered telehealth. But in some cases, they do consider telementoring or teleeducation of patients telehealth, like if you're educating them through an app, or mentoring a resident over the phone or video, or a specialist mentoring a generalist. Social media, not really. There's not any patient-provider relationship. There really shouldn't be, directly at least. And then the last one is online questionnaires, like when we send out survey monkeys and stuff like that. It's more research and not really telehealth. So these are the other categories of telehealth I was going to go over. Televisits, again, this is kind of like the real-time thing. Video conference over the phone or computer, after hours coverage, telehospitalist, telenocturnist. This can be seen a lot of like primary care, specialty care, home hospice, a lot of those. Teleconsults, this is the one that's really big in Northwell right now, which I'll get to later. But basically real time as well, a provider in one location presenting a case to an expert in another location, with or without the patient present, or like some imaging too. So like ICUs consulting each other or getting psyched remotely somewhere else, or like telestroke, which I'll talk about, tele-neuro ICU. And also sometimes within the same health system, you can consult different specialists in another hospital. Like New York Presbyterian has set something like this up, where like you could consult a cardiologist at another hospital. Telesupervision, this is really, kind of imagine like when you're on night float and you're presenting to Dr. Ornstein or Dr. Matthew, but imagine that they just never come and see the patient and they're just somewhere else. Kind of like that, or like a nurse practitioner or something, but they'll use like video conferencing for that kind of thing. Teleinterpretation, you may hear this like whenever you get something from VRAD, virtual radiology, it's teleradiology. You get a lot of teledermatology going on. There's also like whenever we send a pic of someone's bleeding ulcer to one of the GI fellows, it's kind of like teleinterpretation as well. And the last one is telemonitoring, which I'll talk about in a bit. So just briefly going through a history, because this isn't as pertinent really to my. So basically, it goes back to when the telephone was invented by Alexander Graham Bell. That was in 1876, and then in 1924, there was this idea called the teledactyl, and it's not a dinosaur, and it's also not a real invention either. It's just fake. It's just a fantasy. But he was imagining, Dr. Grunschbach was imagining a tool where you could have a video feed with a patient, and also remotely operate a robotic hand to examine them. So we haven't done that, but that's kind of like robotic surgery. It's real now. And in the early 60s, they had the first interactive video link between Nebraska and Virginia. And then telehealth really took off around the 60s when NASA was like, oh, we need to send people into space. How are we going to take care of them? So kind of taking care of the health, remotely. And then they also funded a lot of stuff in the US and around the world, and that kind of got a lot of stuff started. 1967, telehealth started with airplanes and airports. This was kind of touched on by Liz Sharp's GMC. And then in the 70s, NASA actually partnered with Indian Health Services to really establish the first program of rural care, bringing access to rural areas. And then 1989, maybe a year that some of us were born in this room, but the internet was invented and everything changed. And then a few years later, the American Telemedicine Association was officially formed. So then people were like, okay, this is a legit thing that's gonna push forward with legislation and everything. 1999, the CMS, or Center for Medicare and Medicaid Services, they started to reimburse some telehealth, which we'll talk about a little later. And then video chat, Skype came out in the 2000s, and lots of legislation came out in the 2010s. And then mobile apps have exploded in the last few years. So looking forward, we're going to start to see that people are going to go under this algorithm. They're already kind of doing this. They're looking at WebMD, stuff like that when they're sick. There might be artificial intelligence chatbots in the future. And then if that doesn't work, then they'll go to a virtual telehealth visit through a video conference. And if that's not enough, they need to come in to get examined or get surgeries or go to the ED. So I'm going to go through some of the evidence for telehealth. Okay, so starting out with some health outcomes. So there's been a whole bunch of telehealth studies that have suggested that when you use telehealth efficiently, it can improve outcomes. But what does that really mean? So the first one I'm going to go over, these first two have to do with telehealth as a case management tool, namely with patients who are difficult to reach, don't come to appointments much. So the first one was a 2006 randomized controlled trial looking at diabetes patients who were underserved. It compared telehealth care versus usual care. And essentially what they found was a significant reduction in the hemoglobin A1C levels, systolic and diastolic blood pressure levels, and LDLs. There's a systematic review that went over some chronic care conditions, mainly heart failure, stroke, COPD, and this one showed decrease in admissions, length of stay, ED visits, and even showed some decreased mortality rates in some of the studies. And also there was an analysis that looked into patient satisfaction with virtual versus inpatient visits. Really, people were just as happy with virtual as inpatient, or at least not more sad, but they liked it. Okay, so this other one, I'm going to look into televisits and telemonitoring. So high-risk pregnancies. There was a program at the University of Arkansas that basically used call centers 24 hours a day to answer questions for patients and care coordination for patients that had high-risk pregnancies. And it was widely considered to be a success. There were significantly reduced infant mortality rates. And then out in New Mexico, Project ECHO was this program that deals with hepatitis C management. And basically what they found was, obviously there's a lot more hepatitis C specialists in academic center, but out in the community, in the rural areas, it's mainly primary care doctors managing a lot of this. So what they did was they set up a lot of video conferences between these hep C specialists and the primary doctors, and they found similar health outcomes. No real significant differences in terms of the patients that were treated in the academic center or by community physicians. And on top of that, they surveyed these primary care physicians, and like 3/4 of them actually said they spread the knowledge to their colleagues. So they felt a lot more comfortable with that management, all as a result of telementoring. So I know I just touched on that a little bit. There's a lot more studies. I'm going to move on to telemonitoring. So just this picture, it looks pretty cool. I think this is because ever since mobile health devices came out, things just look cooler. But a lot of the Google images were like very old, like flip phone things. Anyway, so telemonitoring, it's when patients use equipment at home to remotely send into the hospital or the primary care office. This can include anything from blood pressure monitors, glucometers, pulse ox, peak flow meters. Like if they're really short of breath, you don't even ask them; it's already there. If they took it, it's a big if. And scales, so you can see what their weight is. You can get this data at home. It'll get transmitted to the office, and then it depends on the system that people will set up. Either nurses or someone will look at it and report to the doctor. The doctor might look at it themselves from time to time, but that's kind of difficult. Or what they're trying to set up a lot of the time is automatic transmission. Basically, the computer will analyze trends, like blood pressure, blood sugar, stuff, or weight, and see if prompt the doctor to call them in for a visit or to consider sending them to the ED. And then there were 2 major systematic reviews I looked at regarding telemonitoring that had to do with heart failure only. And it was kind of conflicting because there were 2 major systematic reviews that showed that there was a significant reduction in all-cause mortality and heart failure-related hospitalizations using telemonitoring. But then after that, there were 3 major trials, the largest of which was called Teleheart failure, and they showed no difference in either of these endpoints. So what do we do with that? I think it doesn't tell us that telemonitoring is useless. It really speaks more to like telemonitoring can be used, probably you want to combine it with televisits and other parts of telehealth to make sure it's a success. This is just an example of some new remote patient monitoring. It's called a Biometric Patch. This one specifically is called Vital Patch. That's the brand name, but there's a lot of brands. It can detect like a single lead EKG, your respiratory rate, heart rate, your skin temperature, and even your body posture to see if you're at risk of fall. And it can count how many steps you've been walking. And it's like single use, disposable. It has rechargeable batteries. You change it out in 3 to 5 days. They've also used this in patients sometimes. There was a Netherlands 2017 pilot study where they compared the use of these patches to the usual nurses monitoring vitals. And they used something like a Muse system. That's not what they called it, but they compared how good this was compared to usual nursing to look at patients who might get sick and so forth. And they found no, it was generally consistent, like they were about the same. The biggest error was in the respiratory rate, because you know how respiratory rate can be. Yeah. Next one is, I'm going to talk about just like hypertension and telemonitoring. So, you know, hypertension, it's a big love and hate of mine, because I get so many patients that, you know, their blood pressure is a little borderline or kind of high, but just a one-time thing. And you say, okay, do you have a blood pressure cuff? Oh, no, I'll prescribe you one. Is that, will you take it, like, take your blood pressure once or twice a day and bring it back next time, or keep a log? And they're like, oh, sure. And it never happens. So, you know, if they were somehow, like, what if they were doing it but they forgot to bring it? Then I can't fault them. But if they had some sort of telemonitoring where it just uploaded straight, or they texted it to us, then it could be better. So what this was a 2012 prospective study in the UK at 10 general practices, where they kind of did a simple telehealth intervention. This one was just patients texting blood pressure values to the office using a Florence app, which is kind of like WhatsApp, it's encrypted. And what they found was, you know, they did increase significantly how often they had interventions, like changes in their blood pressure medications, and then also a lot more, what was it? Oh yeah, of course they receive way more blood pressure values than the usual care, obviously. Like 11 readings a month versus 0.2 a month. And they also showed some decrease in the systolic blood pressure compared to the usual group. The blue curve down there is the patients who underwent the telemonitoring intervention, and then the purple one up there is the systolic for normal people over a period of 3 to 6 months. So, okay, so another thing that telehealth has really been good for is improving access to care. We kind of touched on this already with Indian Health Service, but basically it's not just rural patients, it's really increasing the access between all of these groups, like primary doctor to outpatient specialists, physicians to patients, hospitalists to patients, hospitalists to talking to the primary docs, everything. If video conference is set up properly. And improving access to care, it doesn't just mean like, oh, I didn't have access to this doctor and that's it. It also has to do with timeliness. Like through telehealth, you can actually get appointments much sooner. And then they'll also, by doing the video conferencing from home, it's kind of obvious, but they'll avoid having to travel to the clinic, so they'll avoid long travel times, avoid travel expenses like Access-a-Ride, or if the gas is expensive, risk of crashing your car on the way. And just a few organizations that, so Indian Health Service, like we touched on, has already incorporated it into its infrastructure pretty well. And the VA is another example that's also been doing it for more than a decade. There's been more than 600,000 veterans getting about 2 million episodes of remote care at 750 outpatient clinics and 150 VAs. So, and then why did I put Alaska here? It's because it's a pretty rural state, and they did a study there that had to do with how long patients had to wait to get an appointment with ENT. So they compared people that had telehealth available versus usual care, and the people with telehealth got to reduce their average wait times to 3 months instead of 4 months for an appointment. But it helped. It's something. So it's something to wake you guys up. It's stroke code Bruno Hall. So telestroke. You guys may have noticed when you get called for stroke codes that sometimes you get down to ED. It's like a weekend in the evening. And they're like, oh, we're just testing the telestroke. It's false alarm. So That's all I knew about it before this. But apparently, it's a really big thing. It's actually the largest and fastest growing telehealth intervention in the past decade for the treatment of acute stroke. And the issue for a long time was that there's a lack of access to stroke expertise at a lot of hospitals, whether it's rural or even smaller hospitals in suburban areas. So basically the proper use of TPA was withheld in a lot of cases because people just didn't, weren't interpreting the stroke scale right. So what telestroke really does is it's been shown to be effective to promote the use of more TPA. So I know we talk about how Dr. Azar pushes a lot of TPA, but maybe that's a good thing because, well, they've done lots of studies and it's shown that telestroke, it hasn't been shown to increase significantly intracranial hemorrhage or anything and also it properly increases TPA in a lot of cases. And it's also, telestroke as an intervention is also a class 1 recommendation by the American Heart Association. That's why I put that picture there. It's a level of evidence A. So, but there's still a lot of progress to be made. This is a picture of the hospitals in Northville right now that have telestroke set up. That's us with the yellow circle. Basically how it works in most cases is that you would have 3 things, like physician, the stroke attending, wherever they are, the hospital, and then comprehensive stroke center. But in our case, we kind of are the comprehensive stroke center, so it's just between those two, but if it was one of the other hospitals, then it might work with all of them. And then the way it works is that you have this mobile cart in the ED. Some of you guys might have had that. That's basically just so that the stroke attending can evaluate the exam. So what's the status of telestroke at Lenox Hill? It's actually fully implemented now. It may not seem that way, but that's because it's only operating after hours on weekends from 5 p.m. to 8 a.m. So that's that. I guess that helps because we're pretty understaffed on the 7 o'clock on the weekend. So 4, finally getting to the hurdles to implementation. Like, if telehealth's so big, why is it not bigger? Well, first, let's go to, there's a recent patient survey. It was pretty recent, and basically patients said that 83% of them said they've never used telehealth, which I find believable. But they say that they'd be 70% likely to choose a doctor if they knew they were offering telehealth. And there's also an issue with poor perception. I'm kind of guilty of this too. Basically, people generally think that telehealth is convenient, but you sometimes hear reports in the news about someone getting antibiotics inappropriately because they called someone and just got antibiotics. But a recent survey showed that a lot of people do think that virtual visits have lower quality care than in-person visits, which the studies have not shown to be true overall. And a lot of people would assume you would have to trade the convenience and familiarity. Like, you think you only have 2 choices. Either I go to one of these services, video conference with a random doctor I've never heard of, or I go to my doctor. But the truth is, more and more doctors are starting to adopt this technology in their own practices, so you can maintain continuity while not having to come to clinic. The other thing is that pretty much all of these, I didn't look into all of them, but the ones I did look into, they all employ board certified doctors like us. So if anyone's doing anything wrong, that's really on them. But they really should be, they have to understand the limitations and know when to take people in for in-person. So I'm not going to go too much into the politics of all of these. It's out of the scope of this, but I did know that I went to a bunch of their websites, and I think that one way to improve perception of telehealth, televisits with patients is I think these companies are doing a pretty good job. They put out a lot of ads which get you to go to the website, and then they have a lot of information on the websites that's actually pretty accurate for the most part. I learned a lot from them, and they have good sources that they link to. So I wouldn't say that's a generalized statement, but that's one way. And the other way is, as telehealth gets more and more integrated and mainstream into our system, of course people are going to understand it more and more. So getting to some barriers in the regulatory and licensing. So regulatory concerns, which visits are subject to this? This really comes down to one question: is the visit between a physician and a patient. Because if that's the case, then yes, they're subject to all the regulatory concerns. But if it's between providers, which actually in some states you can bill for just like televisits between provider to provider, maybe over consulting, then they're not as subject to the same regulatory concerns. The other thing is physician licensing and malpractice coverage has been an issue. And the data out there is very variable and always changing. It's state dependent, can get very specific. And I'll just give you one example is that like physician to provider visits versus physician to physician teleconferencing, even that will vary between states as far as like whether you have to be licensed in that state or if you can do it across the state or which malpractice you're going to want to get. So you have to kind of look that up specifically if you want to practice in certain states. The other thing is reimbursement for these visits. So I mentioned before that in 1999, Medicare started reimbursing for some of these televisits. However, up till now, they still only cover for patients who live in rural health professional shortage areas. So that's an issue. And then Medicaid may be a little better, but it's very state dependent. You have to look it up too. But in New York, it is covered, but as fee-for-service and not as value-based care. And then as far as private insurance, that varies too. You just have to call your insurance. And then telemonitoring, it's very limited. Right now, it's not great. The best hope is basically waiting for payment reform. Or like if you want to do it, it has to be indirectly, like you're doing it to prevent admissions, which later on will save money. But directly for telemonitoring, you're not going to get paid that much for just giving them a device and remotely monitoring it, which takes a lot of time and effort. So. The other thing is the Macra. Was a big thing back in 2015, Medicare Access and Chip Reauthorization Act. It had many things, but I'm just going to say that as far as telehealth, it did mandate that telehealth be shifted from fee-for-service reimbursement to alternative payment models, which focus on value-based care and everything. But the thing is, they just said in the coming years. So, the progress on that is slow. And then, but once this does happen, it'll increase the financial incentive for us to get the ball rolling on telehealth more, to eventually downstream reduce patient admissions and ED visits and stuff like that. So I just have a question for the audience. Is what effect do you think that telehealth will have on healthcare spending overall? Like, do you think, raise your hands if you think that it's gonna decrease healthcare spending overall. Okay, cool, it's most of the room. How about like if you think it's gonna increase healthcare? Okay, so there's like 2 or 3 people. So yeah, generally you would think that it decreases, and a lot of people who give these presentations just assume like, yeah, it's gonna decrease the spending. But you have to kind of think of a few factors. First off is like, are these televisits adding on to the additional, adding on to the current visits that are already existing, or are they substituting out for those visits, like replacing them? So essentially, you have to, on some level, replace those visits instead of adding more. So they did a study on spending patterns in terms of getting televisits for low acuity stuff like sinusitis, and it found that only 12% of those sinusitis televisits were substituted for usual care, while 88% were added on, like new use. So in that study, annual spending on each of those people was $45 net positive per telehealth user. But of course, that's just one study. So what are some ways that we can ensure that telehealth gets substituted out instead of just adds on? One way, like we said before, is transitioning the reimbursement to value-based payments so that people have incentives to use it to like prevent, like don't just add it on, basically. Use it to prevent worse outcomes later on. The other way is we can't let patients get away with it for free. Like we can't, I mean we can, but I'm just saying like, if we have patient cost sharing, meaning like they pay co-pays for this and stuff, then they're more likely to say, okay, I'm just gonna use this when I feel like it's necessary. Because you all know those patients that just call in for everything. Like they call in for everything. Imagine if they had this option, they'll try to do it all the time. So, so there has to be some check there. The other thing is that a relative cost difference. So what do I mean by this? Is that, so there was this recent legislation in which 13 states passed that there's like a parity law where they mandate that televisits have to be reimbursed the same as in person. But you think that's good for us. It does sound good for us. But the thing is, if you do this, you're not really reducing healthcare spending, really, especially if a lot of these will be additive encounters. So there's an argument out there that if we reimburse a little bit less for these televisits, then it might overall decrease healthcare spending more. And then it might be okay for us. We might be a little better, but like we get more flexible hours with televisits, and it's easier for the patient. So, and then the next thing is preventing downstream care. I kind of touched on this already. Just seeing them more often may reduce further admissions down the line. And the last thing to consider is just forget about all this spending. Telehealth is probably going to be great for increasing like awesomeness of society. Well, that's not very academic. It will just be very beneficial to life and society in general. Like people will, reduce dead space in terms of their travel. Like they won't be in a car unnecessarily all the time to go to appointments. They won't lose time at their job. Healthcare professionals might be more happy because get more flexible schedules, and then overall people would maybe have better health outcomes, less readmissions and everything. Even if it ends up costing a little more, maybe it's worth it in the short term. And then just here are some of the most well reimbursed telehealth interventions based just on how government reimbursed them. Radiology, so teleradiology, home health care, when people send home health, and that's cool. And then telepsych, and then prisoner health care, because I guess a lot of, I don't know why, but a lot of doctors may not want to go to the correctional facility. So the answer is it depends. It can decrease in specific scenarios. It might increase if we don't manage it correctly. But overall, it may benefit society. Another hurdle to this is a lack of training. So guys, raise your hands if any of you got trained in telehealth in med school. Oh, where'd you go?
Hofstra.
Oh, Hofstra.
They brought us to the call center for like the ICU telehealth they have.
Oh, that's awesome. Did you meet Dr. Chandra?
I don't remember.
I don't know.
But they like showed us how they zoom into patients.
Okay, so she was just saying how they took her to the tele-ICU out at Hofstra. Yeah, so that's cool, but the thing is this survey showed that over half of physicians say that we just have a lack of training overall in terms of telehealth. And actually only one medical school formally incorporates it into its M1, M2 curriculum, and that's NICOM in Arkansas. So, but I saw that some schools do offer electives in telehealth, maybe Hofstra, but I know NYU has one for students. So, going on to the last topic, trying to convince you guys why telehealth is here to stay, why it's a stronghold of modern medical practice. So, I'm going to give you a big number with lots of zeros. $5 billion USD is the estimated savings for healthcare worldwide as a result of telehealth. And most of these are from North Americans, comprising like about 100 million televisits. Seems like a big number, but really it's not that big if you think worldwide. Worldwide has to do with trillions and stuff. So, but it's a start. It's pretty significant. And in 2017, they did this survey of telemedicine executives. These have to do with executives in hospital systems, healthcare practices, some of these telehealth providers. I pulled a few numbers, there's a lot more, but 98% of them, so basically all of them, for the most part, feel that having telehealth services will make your organization competitive over other organizations. It's partly why Northwell has adopted so much of it. They all agree that reimbursement and licensure is just a big issue that's still being worked on. And 84% thinks that having telehealth services will expand an organization's coverage and reach. Some more numbers. In 2015, telehealth was a $23 billion market, according to some market research report last December. And in 2017, over 200 bills in 40 states and Congress are starting to propose expansion to cover different areas of telehealth. And based on a annual compound annual growth rate of 18% or so, they're projecting that by 2021 it'll become a $66 billion industry. So it's really, really growing. Just going over some legislation. So VA is already using telehealth a lot, but there's this was called the VETS Act of 2017. They just wanted to expand telehealth coverage even more and allow providers to practice across state lines for the VA. It was actually signed by the House and the Senate already, but they were slightly different versions. They just need to await a little bit of reconciliation before sending it to the POTUS president. Opioid crisis is huge right now. Telehealth could help a lot, but the thing is telehealth right now does not cover addiction treatment centers or community health centers. Like, it's not being reimbursed well over there. And this act proposes that we be able to prescribe controlled substances over telehealth without ever meeting them in person before. And this is more like talking about naltrexone, buprenorphine, like Contrave, stuff like that. And then it would also provide more leeway to prescribe MAT, which stands for medication-assisted therapy, which is a combination of medications plus counseling behavioral therapy. So this is not signed into law. It was just unveiled last month. We'll see what happens. So this is a tweet by President Trump in February. He said he just signed a bill. Our military will be stronger than ever. We love the military, get lots of jobs. But these bills have a lot of things in them. And one of the things that this bill had was something called the Chronic Act in it, or Creating High Quality Results and Outcomes Necessary to Improve Chronic Care Act. It's a mouthful, but basically it was a bill that really expanded telehealth coverage. Some highlights of it include, starting in 2019, it would eliminate geographic restrictions on where telestroke can be used. So that's good. And then it also expands telehealth coverage under Medicare Advantage Plan B in 2020. And it'll give accountable care associations, or ACOs, more flexibility to use telehealth services. So I know that's kind of vague, but that's basically, like, people are excited about this. American Heart Association wrote a whole statement about it. It's a game-changing bill. Senator of Hawaii is excited. It's big, but it's a major step, but it's still pretty limited. Still needs, but it's a good step. So now I'm moving on to the reason why we're here in this hospital is telehealth at Lenox Hill. So I spoke to the medical director of the Telehealth of Northwell, and there are 5 main things going on here. First of all, telestroke. Spoke about that. It's amazing. Telepsych. So one time I had to call psych overnight in the CCU, and they were like, sorry, we're not here after 10, but they're always here in the ED. But that didn't help me, but it helps the ED. So if the ED, any time of day, 24/7, needing psychiatry, they can use telepsychiatry. And they actually, the data from Northwell shows that we've been able to decrease the wait times for these psych patients by 88%. They're waiting 88% less time in the ED. Next thing is what Liz Ballou was talking about, EICU out in Long Island, where Hofstra students may have been taking. So it's basically our tele-ICU. Dr. Chandra, who I spoke to, is the director of the tele-ICU out there in Siosset. This started in about 2014, and at Lenox Hill, it's twofold. It's involved in our SICU and the neuro ICU. Basically, before I get into the details, they are spying on 80s and 90s 24/7 with video cameras and all the vitals and everything. So the way it works is 24/7 monitoring system. They have access to imaging, vitals, our notes, and they have a live video, like I said. There's always a telehealth attending on shift at all times. But you may wonder, what's the point of that if there's an attending here? So it kind of serves as backup. The system monitors trends in the computer that maybe the on-site attendings might miss, and it'll alert the telehealth attending to investigate more, and if it's real, then he'll call in to the other attending and be like, hey, maybe we should look at this together. So that's pretty cool. And the other thing, the neuro ICU, is it's basically there's a neurointensivist remotely who actually covers our neuro ICU at night. So he gets signed out at night, covers, they call out to him or her. telehospitalist, this is an interesting thing. I actually spoke to one of our residents last year, Dr. Kevin Lazo, about this. He's certified in it. So are some attendings at our hospital, maybe in this room. But basically right now there's only like 12 p.m. to 10 p.m. shifts that you can take on. It's only at Southside and LIJ right now. They're trying to expand the program to other hospitals, trying to make it 24 hours. And the last thing that Dr. Chandra, he called this was a sexy development, which, I don't know, doesn't really concern us as much, but apparently we have an inpatient peds service at this hospital. I know there's a peds department, but they are establishing a tele-peds ICU so that those pediatricians here can reach out to the PICU attendings out at Cohen Children's in Long Island to get consultation advice. So this is kind of a lot of the categories we just talked about. These are the different things out in Northwell system, which is out of the scope of this talk. The man right there with the glasses, that's Dr. Sara Chandra, who I keep referencing. He's a nice guy. Okay, so I mean, just to end my talk, I just wanted to introduce this idea that has to do with telehealth that's pretty exciting, that I was going to make as part of my presentation, but it clearly is a whole nother topic of its own, and I'm already at the 45-minute mark. But basically, you look at the care spectrum. You know there's the ICU, there's 7 luck, there's the regionals, and then you send them to rehab, and then they go home, and then there's telehealth. The thing that telehealth we've been looking to is this idea of a home hospital. So when I first heard about this from Dr. Report, who helped me with this, I was like, what is that? That sounds like a fantasy, like some sort of future thing. But it's actually happening in like New Zealand, Australia, France, UK, this idea that they get triaged to the ED, and instead of admitting to the floor, there's certain patients who are less acuity that they just admit home and have like daily home visits and use a lot of telemonitoring to do it. And it's like reduced costs, like similar outcomes. So it's pretty exciting. It was pioneered by a guy named Dr. Bruce Leff out of Johns Hopkins. There's some recent work over at Brigham and Women's by a guy named Dr. Levine. So it's pretty interesting. And just to conclude, really, telehealth is everything. Basically, tele-ICU, and then that could apply to the step down. And then in the regionals, you have your telesupervision, your telehospitalist, and home hospital, of course. And then rehab, they actually are setting up telehealth at this rehab center next to North Shore Hospital. Basically, when people get fevers and stuff, instead of sending them straight to the ED, sometimes they treat them with antibiotics and fluids and then prevent readmissions. So that's pretty good. And oh yeah, home visits. Home visits with visiting nursing services. It's also kind of a big deal. It's one of the things that gets reimbursed more. Northwell hasn't really gotten there yet. Dr. Chandra said we're kind of working on it, but it's not really there. Mount Sinai has a much better thing set up. I'm just going to leave you with this quote from the inventor of telehealth in a way. Basically, one day we'll be able to see the people that we're speaking on the telephone with. And yeah, and special thanks to the chiefs, Dr. Report, Dr. Chandra, Dr. Lazo, and my fiance.
Thanks, Alan. Dan?
Did you come across anything about like liability, or if some of these devices were to have problems or fail?
Sure. So I did look into that, and I didn't have time to put it in, but basically we're looking at a lot of these devices. They're very new. It still hasn't got a great footing yet. So right now they're forming, or there's this idea out there that we'd have to regulate them somehow, right? Because there's not that much data for telemonitoring as far as like how the devices may fail or how logistics and stuff like that. And the technology is evolving much more rapidly than the studies are being done. And so one proposal was that right now there's like pharmacy and therapeutics committees, P&T, that go over biomed devices like blood pressure cuffs, aneurysm clips, bandages, random stuff like that. So maybe we can get experts in these telehealth technologies, incorporate them into these committees, make them like digital health committees, and have like expert judgment to kind of regulate and put forth stuff like that. But there really isn't, as far as liability right now, not that much out there. It's still in work in progress.
Dennis, just to answer that, the FDA actually